Hi, I'm Merel Huig,
And I'm Nanda Provost.
and we are presenting the pulmonary embolism rule-out criteria, for short PERC, to rule out pulmonary embolism or PE in the emergency department. In the cure and diagnostic workup for PE in the Dutch EDs, the years algorithm in suspected pulmonary embolism is used. First, the physician looks for the 3 years items, which are clinical signs of deep vein thrombosis, hemoptysis, and the clinical assessment whether pulmonary embolism is more likely than another diagnosis. After the assessment, a D-dimer test is performed in all patients. It depends on the outcome of year and the D-dimer whether pulmonary embolism can be safely excluded without a CT scan or that a CT scan is indicated. With the use of PERC, unnecessary use of diagnostic tools like D-dimer and CT angiography could be avoided.
But first, what is the PERC rule?
PERC is a decision rule made by client for diagnostic workup of pulmonary embolism. It consists of the following 8 criteria. An age over 50 years, a heart rate over 100 beats per minute, an oxygen saturation on room air over 95%, unilateral leg swelling, hemoptysis, recent surgery or trauma within 4 weeks, prior PE or deep venous thrombosis, and the use of hormones. When a patient has none of these criteria, the patient is classified as PERC negative, which means a low pretest probability and no further diagnostic workup is necessary because PE is ruled out.
Secondly, what is this research about?
PERC has been validated in multiple studies. However, PERC has generally been tested in populations with a low prevalence of PE. Studies showed that in European countries, in this review the Netherlands, the prevalence of PE in the emergency department is high. Thereby, the literature about the validation of PERC is possible not suitable for this population and has unsatisfactorily been reviewed. Therefore, the question whether the PERC rule is validated in a setting with a PE prevalence comparable to the Dutch ED will be reviewed in our article.
How did you research the question?
To answer the question, the databases PubMed, Cochrane Library, Medline, Embase, and Web of Science are used to collect articles. Articles were included when the PE prevalence in the study populations did not differ more than 10% of the prevalence of PE in the Dutch ED, which is 20.4%. We did a quality assessment on the remaining articles with adjusted version of quotas.
What are the results from the research?
261 results were found. After excluding 256 articles by using the excluding criteria, 5 articles were left. The prevalence of PE in the used studies were 21.3, 23%, 12%, 29.8%, and 10%. The false negative values present the patients which are classified as PERC negative but did have pulmonary embolism. So a low false negative value is better. The values were 5.4, 6.7, 0, 5.4, and 1.9.
So, what can we conclude out of this result?
By using an angiography, 1.7% with a confidence interval of 1 till 2.7% of PEs are missed. So, PE can be safely excluded when the upper limit of the confidence interval is less than 2.7%. In this review, 4 out of the 5 studies had a false negative value above 1.7%. All 5 studies had an upper limit of the confidence interval above 2.7%. So, thereby, we can conclude that the PERC rule cannot safely rule out pulmonary embolism in high prevalence populations in the emergency department. We hope that this view of the use of PERC is helpful for the doctors on the emergency department, whether to use PERC or not in a clinical assessment of pulmonary embolism. Thank you for listening to our podcast. Goodbye!